Hello, and welcome to the Osteogenesis Imperfecta Foundation's monthly podcast. My name is Tracy Hart, and I'm the CEO of the Osteogenesis Imperfecta Foundation. Each month, the OI Foundation brings you information about the diagnosis and treatment of OI presented by an expert in the field of osteogenesis imperfecta and rare bone disease. The podcasts are a part of the ongoing educational effort of the newly formed Brittle Bone Disorders Consortium, part of the National Institutes of Health's Rare Diseases Clinical Research Network. The professional education activities of the Brittle Bone Disorders Consortium are led by the OIF. Our podcast today will focus on pulmonary issues and OI. And we're very excited to have with us today Dr. Robert Sandhaus of National Jewish Health in Denver, Colorado. Dr. Sandhaus applies his experience with internal medicine, pulmonary disease, critical care medicine, and the biopharmaceutical industry to the study of lung disease. Dr. Sandhaus serves as the clinical director of the Alpha One Foundation in Denver and the medical director and executive vice president of AlphaNet. Dr. Sandhaus is also a member of the OIF's Medical Advisory Council and a former member of the OIF's Board of Directors. So welcome, and thank you so much for being with us today, Dr. Sandhaus.
I'm really glad to be able to be here today.
Great. So we're going to get right into our questions, and I think the first question that I have for you is maybe we can talk about having good respiratory health or healthy lung function in general. And what are we talking about? I'm not sure people really understand how respiratory health affects our health in general. So could you kind of give us a brief explanation of that and maybe what types of terms that people will be hearing when they're having, a lung function test or something?
Great. Well, it's hard to talk about problems with the lung without understanding what the respiratory system is made up of and does. Generally, we consider the respiratory system to include everything from the tip of your mouth and nose down through into the deepest parts of your right and left lungs. And the job of the lungs is to essentially put the outside world in intimate contact with your blood. It does that so that it can exchange oxygen, get oxygen into the bloodstream so it can power all the tissues of the body, and so that you can exhale carbon dioxide, or CO2, which is a byproduct of the burning, if you will, of the fuels, oxygen, and proteins or sugars that you might consume to make your muscles work, make your brain work, things like that. There are lots of places where the respiratory system can get into trouble, right from the nose, having a stuffy nose, having a sinus infection, things like that, down through the larynx, the voice box, which among its many functions is to make sure that food and water go into the stomach and air goes in and out through the lungs, and never the twain shall meet, except that sometimes never isn't actually the case, and you can get things that shouldn't go into your lungs going into your lungs. Then there's the windpipe or trachea that brings the majority of the air down towards the lungs. It branches like tree branches into bronchial tubes and eventually into air sacs that are little microscopic grape-like appendages on the very ends of the smallest bronchial tubes, and that's where the work of the lung takes place. That's where the oxygen and the carbon dioxide get exchanged. And obviously, the heart is an intimate part of the respiratory system because it's the organ essentially contained between the lungs that pumps that blood that needs to pick up oxygen from the right side of the heart, oxygenates it, and then sends it to the left side of the heart where it sends that well-oxygenated blood with its CO2 removed throughout the parts of the body. So you can see there are many places where activity is going on, and unfortunately there are many places that where this activity can fail. So when physicians are looking to evaluate whether someone's lung function has been affected by disease, by injury, whatever, there are a couple of things they rely on. They rely on, first of all, something that people call PFTs, or pulmonary function tests, which can be as simple as an office spirometry. Spirometry is a test where you take a deep breath in, blast it out into a tube attached to a machine, and that machine measures how much air you exhaled, as well as how fast that air was moving out of your lungs. And those two measurements can be used to evaluate an awful lot about what's going on in your lungs. Of note, that does not actually measure how well oxygen is moving, into your blood from your lungs. Some of the more important things, but it's a simple way to gain a kind of an overall picture of how your lungs are doing. Physicians may also get arterial blood gases to look at the actual levels of CO2 and oxygen in the blood, as well as what the blood's acid-base balance is. Or a simpler way to look at oxygenation is something called an oximeter, which you can put on a finger or an ear, and it measures how well the hemoglobin in the blood is carrying oxygen away from the lungs. And it's measured as a percent of the hemoglobin molecules in the blood that are carrying oxygen. So by looking at those things, we tend to first, as a pulmonologist, we tend to first divide people with lung problems into two camps. Those that have restriction to the movement of air in and out of the lungs, and those that have obstruction to the rapid movement of air out of the lungs. So in someone who's restricted, that means that all the volumes, the volume you inhale, the volume you exhale, are all reduced essentially symmetrically. And if you have obstructive lung disease, it usually means you can get air into the lungs well, but the exhalation of air is impaired. And just to give some examples, restriction can be caused by the lungs becoming too stiff. For instance, if the lungs have fibrosis or fibrous tissue building up in them so the lungs can't expand correctly. Obstruction is probably better known to people because obstruction to the exhalation of air can be caused by things like asthma, chronic obstructive pulmonary disease, emphysema, chronic bronchitis, things that are damaging to the airways or the alveoli themselves, as opposed to putting scar tissue in the lung. The thing that's often overlooked in thinking about the entire mechanism of respiration is that the thing that drives all of that air in and out is, of course, the chest wall and the diaphragm. The diaphragm sitting below the lungs moves up and down between the abdomen and the lungs and gives you your inhalation-exhalation movement, and then the intercostal muscles of the ribs allow the ribs to move up and down, pivoting on the spinal column like a bucket handle to make the chest larger and smaller as you inhale and exhale. So anything that can affect anything from the tip of your nose to your abdomen to the bones of your rib cage can affect your lung function.
That was so interesting. I learned so much in 5 minutes. That was great. So, okay, we know that, through surveys that we've done here at the OIF and just, being a part of the OI community, we know that some people with OI have breathing issues and seem to be prone to respiratory illness from time to time. So you talked about, the mechanics there, and can you talk about why this might be the case for people with OI?
Well, the first answer is that I really have to clear my throat. This is choking me up. The first answer is that obviously someone with OI can get any of the conditions that any of us could get in terms of lung disease. If an OI patient is a smoker, they can get chronic obstructive pulmonary disease like emphysema, chronic bronchitis. Asthma is extremely common in the general population, which means that it can occur commonly in patients with OI. But there are some specific issues related to OI and the respiratory tract. First of all, in people with severe OI, there can be fractures of the spine, fractures of the ribs that affect the chest architecture and the ability of the chest to act as an efficient bellows to move air in and out of the lung. OI patients with small stature can have more pressure in the abdomen pushing up against the diaphragms, making it harder for the diaphragms to go through their full excursion to get air in and out of the lungs. And something that we're just coming to appreciate is the fact that we know that in many cases of OI, the defect, the genetic defect, is a defective collagen synthesis mechanism. In other words, the body makes collagen, one of the main connective tissue building blocks of muscle, of bone. It makes that in an incorrect fashion, either because of bad collagen genes or bad genes on proteins surrounding the collagen gene, and so that leads to the breakage of bones and the characteristic features of people with OI. But it's not as widely appreciated that collagen is a major connective tissue that makes up the lungs as well. The lungs have a very delicate architecture that allows these air sacs to expand and contract and bring the outside world in intimate contact with the blood supply. And most of that architecture is made up of collagen fibers. It's kind of the girders that hold the structure of the lung together. And so individuals with certain types of OI can have not only derangements in the collagen in their bone, leading to fragile bones, they can also have derangements in the collagen of their lung that leads to usually restrictive types of lung problems where they can't move air in and out as well as someone with normal collagen. And if you add on top of that problems with chest architecture where someone might have kyphoscoliosis that collapses one lobe of the lung or the other, that leads to a situation in which things that the lung that you might inhale with every breath might tend to pool in parts of the lung where the air isn't moving well, and bacteria that you inhale, instead of being rapidly cleared out of the lungs through coughing, through what we call the mucociliary escalator that carries things up out of the lungs so you could swallow them or spit them out, it can lead to a situation where the lungs are actually a breeding ground for infection because the lung's not able to clear those secretions and inhaled particulates and bacteria as rapidly as someone with normal architecture can. So it leaves patients with OI that have abnormal chest architecture and or abnormal collagen in their lungs at greater risk for things like lung infection. Perhaps they're more susceptible to the effects of cigarette smoke than a normal individual would be. And simply the fractures that can occur that affect the structure of the chest wall, whether it's kyphoscoliosis or fractured ribs, can lead to impaired movement of air in and out of the lung and eventually impaired clearance of things from the lung. So it's a complex picture that all seems to be working against OI patients that have problems with the connective tissues and bones of their chest.
So having said that, what can a person with OI do to prevent respiratory illness in your experience?
Well, I think that the knowledge of having these potential issues is important. First of all, if a consideration is being made, if a kyphoscoliosis is worsening and consideration is being made to treating the kyphoscoliosis, one of the elements in that decision-making process should be how will improving the kyphoscoliosis or preventing it from getting worse interact with the lung disease. Because it may be that someone that you would say, it doesn't quite reach the right angle to be of kyphoscoliosis to be operated on now or stabilized now. If there's an element of pulmonary impairment, it might suggest that that person would be pushed towards getting that taken care of. Clearly, there are things you could do to keep your lungs in better shape. I guess the first thing that always has to be mentioned is OI patients, as with anyone, but especially OI patients, should not smoke. If they've started smoking, they should really work on cessation. Family members shouldn't smoke around OI patients. I've talked to OI patients who say, it's the one joy I have in life is smoking the cigarette. Find another joy. So I'm talking from a lung perspective. Then there are various treatments that people can do. There are clearance exercises that people can do. There's respiratory muscle strengthening exercises. Weight loss, especially abdominal weight loss, can really help those diaphragms move better and clear things better. There are cough exercises you can do to clear secretions better. But I have to say probably the most important thing is get evaluated by a physician and treated by a physician early if signs of respiratory conditions occur. For instance, if you have wheezing and shortness of breath when exerting yourself, head to a pulmonologist or an allergist who's experienced in treating asthma to find out, is this asthma, and get on the appropriate asthma medications, which are usually bronchodilators, sometimes inhaled steroids, although that has to be considered in someone with brittle bones. And if there's a history of COPD in brothers, sisters, things like that, probably shortness of breath should be evaluated for those kind of problems, and there are therapies if COPD is treatable. The most important thing is to, early in adult life, get lung function testing because there are problems with testing the lungs of OI patients, especially OI patients with short stature. All of our lung function testing that are done on individuals that have normal stature is based on calculating a predicted normal for a given individual. And that normal is calculated on very few things: your age, your sex, your race, and your height. And height has the greatest impact among those things on what the baseline normal pulmonary function should be. With OI patients with short stature, if the normal values, the predicted normals for a particular individual, are based on the person's actual height, you will underestimate the size that person's lung should be, and you may come back with a result that says, oh, you're 120% of the predicted normal, you're super normal, your lungs are just fine, when in fact the lungs are severely affected. Yep. And so the way that we try to get around that is to not look at predicted normals, but to compare someone against themselves, to get longitudinal lung function testing on a given individual. Get a lung function test when they're doing well. Get a lung function test again when you're doing well. See what direction things are going. Then when you have a lung function test during an episode of shortness of breath or a problem that's been identified, you can compare it to the previous testing and know whether this is normal for you or represents an abnormal lung function test. And you can often tell what type of lung problems a person is having by comparing to their lung function tests when they were normal. There are some ways around the height issue. You can, instead of using height, use arm span. But the problem with arm span is if a person has had multiple fractures of the long bones and has rotting or anything like that in their upper extremities, then arm span is not going to be an accurate substitute for height. So the physician that's evaluating an OI patient has to take all of this into account. And sometimes they need some help from the OI patient themselves to think of these issues in evaluating someone. Now, the tests that we do of oxygenation, like blood gases, like oximetry, are not affected by the things that affect pulmonary function tests. So someone having a low oxygenation or an elevated carbon dioxide level, that's the same, has the same implications for an OI patient as for any pulmonary patient, and would be treated similarly. That there is a whole regimen that we do for patients with any of these lung diseases to try to keep patients healthy. And those regimens include the same things for OI patients as we do for any potential lung patient. That includes prophylactic measures like getting immunized against flu every year, because the major impact of flu on the general population and obviously on the OI patient is lung problems, is getting an influenza lung disease, lung infection, or as often happens, a secondary bacterial infection with a severe case of the flu. The OI patients should be considered in the group of patients who should get pneumonia vaccines. And right now there are two different kinds of pneumonia vaccines that are aimed at different parts of the bacteria that cause pneumonia, and OI patients should get both types of those vaccines.
And Dr. Sandhaus, their physician would be able to tell them, would know which vaccine they should get, the pneumonia?
Yeah, it would be very easy to prepare a card or something that would talk about that. But basically, there's the old type pneumonia vaccine, Pneumovax, which raises antibodies in the body against the sugar coating of the most common bacteria that cause pneumonia, and that should be given early to anyone who hasn't had it. There should be a booster at 10 years after it's been received. That's the one that's been around for years. And then the new ones are these PCV vaccines. They are pneumococcal conjugate vaccines. They actually raise antibodies in the body against the proteins that make up these organisms. And so far as we know, that only requires one injection in someone's life, although time will tell if that's the case. But it can't be given within a year of when the other type of vaccine was given. So you can see it tends to get complicated, but those of us that see a lot of patients kind of have it drilled into our heads when that should happen. But if a patient isn't offered a pneumonia vaccine, they should know to ask for it.
Got it.
Now, the other things that are things like, that I mentioned already, controlling weight, exercise to keep those respiratory muscles in good shape, and having a physician that you can have a long-term relationship with who will understand the changes that you might go through. Because it's tough to see someone with a rare disease and hear a complaint of shortness of breath and know whether that's new for them, even know what to do with it unless they've had a long-term relationship. And unfortunately, with the current healthcare system, it's very tough to maintain long-term relationships with physicians.
Right. This is fascinating. This is excellent information, Dr. Sandhaus. We only have a few minutes left, but I really wanted to talk about quickly, do you recommend sleep studies for people?
Well, one of the things that we didn't actually talk about is a risk for OI patients with, again, especially those with short stature, is sleep problems, sleep apnea, sleep disordered breathing. These are very common issues in people that have anatomic abnormalities of their neck, short neck, thick neck, things like that, which can often describe a severe OI patient. And the people that I've seen and physicians I've spoken to who follow a lot of OI patients find that sleep issues seem to be a major problem in severe OI patients. Doing a sleep study can identify what the mechanism is of someone's sleep disordered breathing. Most of the time, it's what we call obstructive sleep apnea, where the muscles in the back of the throat relax, and that relaxation causes intermittent obstruction to the flow of air where someone actually stops breathing during the night. these kind of intermittent cessations of breathing are just a magnification of the normal resting respiratory actions that happen to anyone during the night. The difference comes when those apneic episodes, episodes when you're not breathing, get to be too long or deep. And there are easy treatments for those. Easy, I have to put in quotes. The things that are difficult in an OI patient is, number one, becoming comfortable in a sleep lab that's not made for someone with stature issues. So we always encourage our OI patients to bring whatever pillows, bolsters, whatever they use to sleep at home with them to the sleep lab, so that they can sleep in the same positions that they sleep at home. Number two, most of the treatments for sleep apneas and things like that involve putting a mask on the nose or the nose and mouth and attaching it to a machine that pushes air into the lungs when necessary. And fitment of those kinds of masks can be a problem in some OI patients. But in general, I've never found something that wasn't solvable in that regard. We should talk about supplemental oxygen if we have time to do that.
Yeah, I think we just have a couple of minutes left, absolutely. And then we're going to bring you back again, too, because this has been so valuable, the information you're sharing. Can't thank you enough. So let's talk about that, and then we'll wrap up.
Great. So, one thing that someone with lung problems, whether they have OI or not, is often recommended is to go on to supplemental oxygen, usually what's called a nasal cannula, where there's a plastic tube with prongs that sits in the nostrils and goes over the ear and down to an oxygen tank or an oxygen machine of some sort. And when that's recommended, it's an important medical treatment. It should be thought of as a drug, because it is something you take that has a medical action. And people with lung disease from OI, people with sleep apnea from OI, people with with emphysema, with bronchitis, sometimes that condition gets so severe that they're not able to deliver enough oxygen to the body for the person to do the things they want to do. So the first thing that supplemental oxygen does is it raises your oxygen level in your blood so that your muscles can work more efficiently. And so you can do more and deliver more oxygen to muscles, heart, and brain and keep them functioning up at peak efficiency. But sometimes, even more importantly, there's a subtle thing that happens when the oxygen isn't arriving at the lung in sufficient quantity. When the lung sees low oxygen levels, it has a kind of a protective mode that it goes into. It shuts down the blood supply to the part of the lung that isn't getting oxygen, so that the blood supply can be shunted to parts of the lung that are getting good air and good oxygen delivered. It should be a very efficient mechanism if the delivery of oxygen is impaired in one little part of the lung. But what if the entire lung is affected and the entire lung's arterial supply is shut down? That puts great strain on the heart, and you can actually get something called cor pulmonale, which simply translated means heart disease due to lung disease. That you get something called secondary pulmonary hypertension, because the pulmonary arteries start to constrict to keep blood from flowing to parts where there's no oxygen, and if that's the whole lung, that's not good. And eventually the right heart can fail. And the treatment for that is supplemental oxygen. If you get that oxygen up again, the blood vessels relax in the lung, the right heart can pump blood through the lungs without impediment, and that's actually reversible if caught early enough. And so supplemental oxygen, once someone is judged to need it, not only lets someone do more with the amount of lung function they have, it also protects the heart from being strained and eventually failing. And so it can be a very important medication for people that have underlying lung disease.
So we are getting the high sign, Dr. Sandhaus. Thank you so much. We're going to have you back again because this is so great. You can visit our website at www.oif.org to find out more information. Dr. Sandhaus, thank you so much.
My pleasure.